So our next speaker is Ian Braithwaite. He's a paediatric transport nurse. He's fairly new to the job, 20 plus years experience, I think, in UK and in Australia. So I think in Australia, I guess you know long transport times. He's an educator. He works for Embrace. He also runs his own course as well. And he tries to teach the standard of what should happen in neonatal transportation and paediatric transportation. We've talked about the general guidelines in the previous talk and the big broad brush sort of guidance, and actually how that can be modulated into a far more precise approach with the ventilation to improve your outcomes. And I think Ian's going to carry on that, albeit on a smaller note because they are neonates, but looking at precision in neonatal transport.
Thank you. I kind of thought I'd get to hold my notes and then they give you a mic in one hand and a button in the other. No, I'll be fine. I should have. Thank you very much. Thank you so much for inviting me down here. Yes, I'm talking about precision in neonatal transport, and I'm going to talk about a patient who I've made up. This is Bobby. Bobby is about 800 grams, 28-weeker, born in a sort of semi-rural hospital in England, on the seaside in Scarborough. I was looking for a good photo of a premature baby, and I was struggling. And my wife said, "Well, why don't you use one of our sons?" So that is actually my son. And I'm a neonatal nurse. I'm a paediatric nurse. We love precision. You only get to do this job if you are obsessive compulsive and passionate about the detail. And that is very useful because we're thinking about the topic of the whole conference, about the sickest patients, the earliest hours. For neonatal medicine, the first 3 days are so important. Some of you may have heard of a challenge we have, intraventricular hemorrhage of the newborn, which are these small bleeds you get in the germinal matrix in the newborn brains. And they often, when they happen, they tend to happen in the first 3 days. They happen to 20 to 40% of neonatal extremely premature patients, and we still don't have a clear idea about why they occur. We don't have a clear idea about how to prevent them. What we do know is they can and do adversely influence the outcome of these patients. So we really want to be able to manage these, and one of the ways that we can do that to the best of our ability at the moment, because it's still a very grey area, is by precision. Now, if you were nursing this patient in a hospital, you might have a care bundle of practices. The individual evidence for each of these practices may not be that strong, but connected together as a bundle, they have been shown to improve outcome. You might focus on putting the head in the midline, elevating the patient, being very precise about your administration of medications, sample your arterial line very slowly, minimize stress and pain, tight control of arterial CO2 and tight control of oxygen saturations. And if you want to hear about a really interesting study, ask me about the oxygen saturation study, how we discovered the right sats to keep these babies at. But you've got this baby beautifully cared for by, obsessive compulsive doctors and nurses in this beautifully clean neonatal unit. And then if I walk up to it, start shaking the incubator, kicking the wheels and yelling at it, you'd call the police, you'd restrain me. But actually, that's what I'm doing as a transport nurse. I'm caking this baby out of this lovely place and I'm creating chaos. And how can I keep that bundle going? How can I keep precision going on this journey and improve their outcomes? So I'm going to look at 3 little ways that we've tried to do it in my service: precision and ventilation management, precision and medication delivery, and precision in the journey itself. If we start with precision and ventilation management, we've got that target of tight arterial CO2 control, because you don't want, because these babies' brains are so sensitive to changes in oxygenation that result from changes in CO2 levels. And we've got a good integrated network of transport units in the UK, and we benchmark heavily against each other. Back in 2015, 2016, my team, we're not very good at naming services. unfortunately. There's some terrible acronyms down there. But we were above the national mean, which for this metric, which is the number of transports where the gas at the end, the blood gas at the end of transport was outside the range 4 to 7 kPa. We wanted to get better than that. We weren't very happy with ourselves. The first thing we did was we bought some fancy new ventilators that meant that we could monitor tidal volumes and have some more precise control. And that did give us a small bump where the line above the national mean was still dropping, but we sort of accelerated a little bit. But we wanted to do better than that because, as you can see, we just plateaued for the years after. We came up against some challenges based around the technical complexities of ventilating patients like Bobby, who were just 800 grams. For your adult, you've got various bits and pieces on your vent circuit that make up the instrumental dead space. I've estimated at about 85 mils here, but they've got a tidal volume of half a litre, so that doesn't really matter. It's only sort of 10 to 20% of their tidal volume. And if we look at what we're doing for Bobby here, I mean, Bobby might have 5 mils of dead space, but I'm ventilating Bobby at 5 mils per kilo. His tidal volume is 5 mils. The dead space I'm trying to manage is 100% of his tidal volume. It's just an area where we think we can possibly be a little more precise. So from left to right, I've got my Y piece, I've got my heat moisture exchanger, I've got my flow sense, I've got my end tidal. The first thing we can do is take out the heat moisture exchanger because we're always using warmed gases on these patients. But that does leave us with the end tidal connector at the end. And we were using end tidal both as, it's the gold standard in transport. It tells you your tube's in, but also we're following the numbers to keep our, to manage our ventilation in terms of CO2 levels. But in our patient population, how accurate was that? So we did a little audit. This is 13 babies. If the end tidal was accurate compared to the arterial CO2, those red dots should be on the blue line in the middle, or at least lined up in something sort of parallel where we could say there was a relationship. But it just didn't seem to be a good relationship in our patients. And yet this was a number which our clinicians are staring at and tweaking the ventilator for on some quite long transports. And yes, we can pull over and we can do a blood gas on the journey, but if you do that constantly, you're never going to get there. So we took something which was coming back into fashion on the neonatal units and we put it on our transport systems, which is transcutaneous monitoring. And this is a tool where by putting a sensor on the patient, warming that sensor, you're bringing the arterial blood flow closer to the surface, and clever engineering can give you a number. And we put this on our transport systems, and the same group of patients looking at the accuracy of the transcutaneous number, it was really impressive. We did not expect that. Very little variation, and it just didn't take any convincing to make that the standard of care for our transports. And that really reflected as well in the improvement in our ability to keep the patients within that 4 to 7 kPa range. We did wonder if we could do better than that. What if we took out the end tidal CO2 altogether? There's a bit of nervousness about this because it tells you the tube's in, but we also felt that even though we were telling them not to, people were still looking at the numbers. It's very difficult to ignore a number, and it's not easy just to put a bit of tape on the monitor. So we did that. We did a lot of education. We focused on the flow loops on the ventilator. If you've got negative flow, your tube is in. And we had a colorimetric indicator on top of the ventilator. So if you had an emergency, if you're intubating, you had something you could use quickly. And I haven't got the numbers for that, but I really do think that is the next step in our improvement. I'm talking about precision and medication delivery. I demonstrated this slide to one of the conference faculty a few weeks ago, and he swore very loudly because I don't think he was used to having to give 3 mils an hour of maintenance to a patient. You can't just hang a bag up on these patients and open the tap. Bobby needs 90 mils per kilo per day on his first day of life. That's 72 mils a day, which is 3 mils an hour. And what's that made out of? Well, Bobby needs a bit of morphine, a bit of muscle relaxing. He's got an arterial line, we need to put a flush on that. No pressure bag in these patients. maybe a bit of dopamine or adrenaline, and the rest maintenance. So 3 mils an hour. But we're asking our infusion pumps to run at some very low rates. And the question that's been asked by some of my colleagues is, how good are they at doing that on transport? The first question they asked was, static height of the pump relative to the patient matter? So these are just sketches of our road systems, the green bits of the pumps. We've got road systems, we've got pumps below the patient, we've got pumps above the patient. On our air systems, we've got pumps at the foot of the patient, we've got pumps above the patient. They're in different places on each of our trolleys. Does it matter? The quick answer is no, it doesn't matter at all, the static height difference of your pump. But what about moving the pump? Because we've always sometimes taken pumps that are already running on patients that are at different heights, moving them across. This graph looks at moving a pump down 50 centimeters. So if you've got a pump that's running at 2 mils an hour, moving it down 50 centimeters, it's like stopping that pump for 2 minutes. But as you saw before, we're not running that pump at 2 mils an hour. We're running that pump at 0.5 mil an hour. So if I take my Braun pump, that's running at 0.5 mil an hour, move it down 50 centimeters, that's like stopping it for 12 minutes. And if I had a setup where I raised that pump up 50 centimeters, again, that's like giving a 12-minute bolus of whatever I'm infusing. So that is something we have to be very careful about. And we have to, wherever possible, keep things at the same height. I had a very sick patient the other day, and when you get to the other end at the hospital, you're saying, right, I want this infusion to be at the same height it is on my transport system. I know your lovely unit has the pumps, up here or down on the floor, but let's keep them the same for now, and you can change them slowly later. We also asked, does vibration matter? These pumps here on this system, the pump on the right, your right, is just fixed. The pump on the left is mounted to a fancy sort of film camera gimbal that stabilizes the footage. And my colleague drove that round and round to look at, does vibration matter? Does it influence how much medication comes out of these things? And the answer is yes, it does. The blue line, the pump without the stabilizing device, started off faster than the pump that was stabilized, and the optimal expected situation was the green line. But actually, after about 5 minutes, everything settled down and the lines converged, which was reassuring. This is a crazy picture. This is, does orientation of the pump matter? So the same group of precision-orientated colleagues fitted pumps pointing up, pumps pointing down, pumps mounted transversely, pumps pointing backwards, pumps pointing forwards, and ran everything at a very low rate to see, was there any difference? There was a difference. If the pump is pointing in the direction of travel, so you were squeezing the pump and you're heading in that direction, that's the green line. You get more out of that pump. If your pump is transversely mounted, so it is just traveling parallel to the direction of transport, you get the lines which best fit what you expect going up. And that didn't converge to a steady state over the journey. Came out of the pump, which was mounted in the direction of travel. Second worst was the pump, which was mounted going backwards. So there's a bit of head scratching about this because, this is one of our helicopter setups here. If this is loaded in the aircraft as it looks here, those pumps are pointing in the direction of travel, you get a little bit more out of that pump. Whereas if you loaded that setup transversely in the aircraft, the pumps are transverse, you get more what the manufacturer tells you should expect to get. And here's another setup here we've got for fixed-wing transport. The pumps, and this is coincidental, this was how they fitted when it was designed. The pumps are mounted transversely. So if you're going, straight ahead, that's a great way to mount them. If you loaded this system transversely in the aircraft or the ambulance, the pumps are suddenly pointing in the direction of travel. So we had to think very carefully about how we start to design our new systems. We've got a road system on the way where actually we've put the pumps on a little turntable because, we're not entirely convinced how this is all going to play out, but we're keeping our options open. So we can point them wherever we want to point them. We did ask, this was all done on 50 ml syringes, and my colleague Patrick at the bottom, and I really recommend contacting him if you want any more on this, because he's putting a lot of effort on this. 20 ml syringes versus 50 ml syringes. A lot of the previous effects I've talked about actually are mitigated by using a smaller syringe, because you've got a far faster plunger speed. And if you calculate some models of serum concentrations, this is a vasoactive drug with a 90-second half-life. You know, the effect that we saw on the vibration earlier just disappears. So it's not always practical, but you know, we are making all our infusions up that are running less than 1 ml an hour in these 20 ml syringes. I was told that you were all geeks and all I had to be was geeky, so I hope that's geeky enough. I also told the guy sitting next to take the odd photo of me, and it just makes it look like there's someone really interested, which is quite cool. And the last thing to talk about is precision and the journey itself. So Bobby's born in Scarborough, little seaside town in the northeast of England in Yorkshire. We've got two options for the level 3 neonatal unit. We can take him down to Hull. We can take him up to Middlesbrough, James Cook Hospital. It's not by the scale of things, it's not long. It's 90 minutes. It's only 50 miles. But it's a really rubbish journey. I mean, the roads are awful. And in holiday time, they're very busy. There's lots of stopping and starting. They're not comfortable by any measure. But all those three places have got great helipads. And we've got the option of flying. It's 40 miles. It's only 20 minutes. We've got the partners and the equipment to do that. And the question we're all asking ourselves is that a good use of our resource? Is that a good use of air transport for this patient? Because we're happy to fly patients to London and to Scotland and to collect patients from Cornwall, but this is, a fairly local distance in our own patch. And this is a sort of active question where we are. It's worth stepping aside just forces that we're putting these babies under. We've got the sort of shock force, which is where you're driving a bump maybe in the ambulance. You've got the acceleration, which is the change in velocity over a period of time. You might experience it when you brake suddenly or go around a roundabout. And then vibration, which is sustained rhythmic accelerations. Engine, tyre, road surface noises from road transport. The one thing that neonatal transport practitioners love to do is they love to measure things. We're always measuring things. Here's a vibration sensor stuck in a mannequin. We've done this for real patients as well. It's a lot easier to measure things and publish it than it is to find a solution to the problem. This is a great paper. It's a very recent French paper where, common to all these measurement papers, they're looking at average vibration in the different modes of transport. And you can see the average vibration for the ambulance transport, 0.32 meters per second squared, is a lot less than the average vibration for the helicopter. But what I thought was interesting about this paper and what's been taken up in other studies was they also looked at the number of shock events, the number of bumps and bangs and high impulse events. And they found that the ambulance in this had 44 shocks versus 8 in the helicopter, and they were different durations. So it's basically for the ambulance, 1 impulsive event every 2 minutes, and the helicopter, 1 impulsive event over 11 minutes. So basically 5 times more shocks in the road journey than in the helicopter. And the authors are postulating that we maybe shouldn't focus all the time on just the average vibration of the journey, but look at these high impulse events which have the potential to impact Bobby's journey. And you can see, another study out of Tokyo where they're just measured. This is just a measure of one journey. I thought it was nicely presented. They're taking a baby from Kyoto to Tokyo. They take the baby up to the rooftop. They put them in a helicopter. They fly. They land for a refuel. Fly in the helicopter, and then when they put them in the road ambulance at the other end, and you've got impulse shocks of 4 to 5 times the average vibration you've got in the helicopter. And as someone who's flown babies, in Australia and in America and in the UK and in Europe, often the worst part of the journey is that short road journey you have to get to the helipad or to the airport. And the baby who's been perfectly well behaved physiologically in the air suddenly starts to deteriorate as you're faced with all these different changes in dynamics and forces. And there's been a couple of nice studies coming out of Northern England, coming out Northwest, where they're saying that what these babies like is static forces. They're okay with a bit of vibration. They're not okay with the changes in acceleration and the changes. So what does precision look like for Bobby and his journey between Scarborough and wherever he's going? Well, something which I think is fascinating. This is what precision looks like to me. This is a team just south of us who are moving babies all the time between Nottingham and Leicester by road. They're only about an hour away, these two cities, but they've got a smartphone in the ambulance attached to the neonatal incubator. That smartphone tells them the speed, the acceleration forces, the vibration, the noise, and they plot it. So these are all the different ways to get from Leicester to Nottingham. The driver's allowed to drive whichever way they want. And what I discovered was ways that the driver said the quietest, the quickest, and the smoothest are not actually the quietest, the quickest, and the smoothest. And they can figure out what the most optimal route is, and it varies on the time of day and the day of the week between any two hospitals in their region. I think that's fantastic, and to me that is just a great example of what precision looks like in the journey of patients. So, and I just credit to my colleague for pointing this out, but for me, neonatal transport is a lot like this bobsleigh team here. The sickest patients, the earliest hours, these races are won and lost in the first few seconds, in the start off, in that initial pound down the track when they're jumping into the bobsleigh. And for the care of Bobby, a good outcome for Bobby is won and lost in the first 3 days of life. And if he has to spend some of that first 3 days in an ambulance or a helicopter, we've got to make sure that we're doing the best we can. And if we do the best we can, Bobby ends up looking like this, which is my 9-year-old son who managed to come out of his premature phase relatively unscathed. Thank you very much for having me here.
What an amazing and inspiring talk. Thank you so much. Any questions from the audience? Well, I have one. The manufacturers of the syringe pumps and all these devices, what do they have to say when you present this data to them? Because presumably they're selling these devices to you, and I'm looking at our sponsors in the background here, based on their precision.
Yeah. That's a very good question. I'm doing a workshop on Friday, actually, at Zermatt, where we'll talk about that a little bit more. But essentially, if you read the very small print in manuals, they say don't use 50 ml syringes when you're running at less than 1 ml an hour. Something a lot of people conveniently don't know.
It's very interesting. I should start reading the things. Question at the back. Do we have a roving mic? Or oh no, sorry, could we just ask you to ask it into the mic for the people streaming at home? Well, maybe not at home, maybe they're streaming at work, I don't know. Or other places, but I don't want to know. Turn your camera off at the other end.
I'll see you on Friday. Yes, hearing protection is very important. You can get these sort of called mini muffs. Never Google that. Things, the noise pressure by about 7 decibels, which is just not good enough, really. So it's quite a lot now of hard ear defenders, which are aimed at the children to gigs. And some of them are sort of baby sizes. I've got a set with me. I'll be showing off on Friday. They reduce the noise pressure by about 30 decibels, which is a lot better. And I would advocate all road and air transport. I have a quick question.
Oh, go for it.
I'm just abusing my position here as a speaker, but I want to go heli skiing. And I asked Patrick, and he said I had to find 3 friends. So come and chat to me later if you're interested.
Well, I think we can sort that out for you, can't we? I've done the heli skiing a few years ago. It is fantastic. I went up there with one of the other speakers who was a ex-Apache pilot, and it was, I think the 2 pilots were trying to show off to each other. It was amongst the most terrifying, exhilarating moments in my life. We have one more question there.
Oh, yes, totally. And this is a real area of interest of mine because, I'm an educator and I'm trying to, teach people to fly safely and to make good decisions. Every team, I think, who flies newborns asks this question. And so there's quite a lot of research out there. So air transport, whether it be fixed wing helicopter compared to road, has not been shown in any study to be an independent risk factor for IVH. I worked in Australia. We did some great work in Sydney where we're doing ultrasound scans of babies before and after road and helicopter transfer and not seeing any development of pre-existing IVHs. There's a lot written out there. Some of it's counterintuitive. You think, well, I'm shaking this baby, surely something's going to happen. But the forces in road transport are also there as well. I think we've just got to, whatever mode of transport we do, we've got to be better at it. And there's some great, clever innovations out there to reduce the vibration. In Switzerland and in Germany, you've got ambulances where the incubator is almost isolated from the table. More things like that, more ways just to keep these babies as still and to reduce these forces. Talk to me later. I could talk for hours about that.
Thank you so much.